Well, good afternoon, everybody. I wasn't actually prepared that George was going to break my news to the room, but anyway, this is completely an apolitical conference. I was just joking there with Paul McGarry, who was saying, oh, I'll have to start and get some pom-poms for my campaign, but that's probably the only, not the only thing I'll take away from today. It's been a fabulous morning, hasn't it? And usually this is sort of post-lunch slot is really difficult to sort of keep you all from nodding off. But after that amazing energizer, I feel like we're all really buoyed up for what's going to be a great panel, focusing on how health and care, together with those of you in the room, with innovators, investors, researchers, can collaborate for healthy ageing. And I'm delighted that we have one of the panel in the room who's going to speak first, and that is Victor Adebowale, who many of you will know was the chief executive of a fantastic social enterprise that delivered health and care called Turning Point. He is now the chair of the NHS Confederation, and also, I think importantly for today's session, also chair of the Social Enterprise UK. And Victor's going to open by speaking to us first. So welcome, Victor.
I think I've got, what, 5 minutes now, isn't it? Something like that. So congratulations, Anna. Brilliant career choice. If you're going to join a political party, to be a prospective MP, join one that's 50 points ahead in the polls. I think you can give people a lot of career advice. If you don't know what I've said, if you'd have said you were the prospective MP for Conservative parties, probably been a few minutes silence commiseration. So, I'm a crossbench peer, so I can slag them all off. I am the chair of the NHS Confederation. I'm also an entrepreneur. You know, I've set up an organisation called Collaborate, which is not a think tank, a do tank, all about how you change public services from the inside out, and how we get people to collaborate in the interests of better services for the people who may be in this room but are probably outside it. So I also co-founded a company called Visionable, which is a platform. It's like Zoom for health, right? A British company, we own the IP, we own the technology, so I know something about entrepreneurship. So I'm going to be quite quick, basically, in what I say next. Health and care can get really complicated really quickly, right? So I like to simplify things. I like to bring things back from the complexity and focus on what really is going on. And I think there are only 3 challenges facing healthcare systems in the first world. And you probably, you know, you've got degrees and all sorts, and you probably argue with me about this, but let's give it a go, right? Only 3. The first is equity, right? A woman in Barking and Dagenham has an active life expectancy of 55. In Richmond upon Thames, it's over 70. That's immoral and it's not sustainable, right? So the thing that connects poor people and rich people is that both people require bespoke services or they don't use them, right? People in the middle, they use their elbows, okay? Equity, first thing. The second challenge is access, and access needs to be deconstructed a bit into the following things. Workforce, which we have a major problem with at the moment, you all know that. It's not just numbers, it's also what are they going to do, right? A nurse in 5 years will not be doing what a nurse is doing now, and the same goes for a load of other things, including care workers, frontline workers. Access is also about commissioning, and lots of commissioning. I've spent lots of times with commissioners. We don't really define commissioning very clearly, so let me give you a definition that actually works. Commissioning is the means by which you understand the needs of an individual and or a community such that you can build a platform to do all the things that you get told is commissioning, like procurement, contracting and purchasing, right? So commissioning, how you actually gain services. And the third is service design. Now, commissioning and service design, you could argue, are connected if you apply my definition. But actually, service design needs to be driven by one principle only that makes the biggest difference for people using health and care services, which is positive value transfer, right? Just a very second on positive value. Difference between positive and negative value transfer. Negative value transfer is the equivalent of you walking into a bank to get 10 quid. I know you use, just bear with me. Walking to a bank to get 10 quid and being told you've got to go to 10 tellers to get £1 each, right? That's negative value transfer. Kind of obvious, really. You're wasting your time going to 10 tellers. It costs the bank 10 times more than it would do if you could go to the bank, go to an ATM inside the bank and get advice on your whole financial life, right? That's positive value transfer, right? So put your hands up, all those that have used the health and social care service that have experienced negative value transfer. Yeah, it's very, very expensive, it wastes time, wastes money. So that's the final principle of the access point, right? And the final of the three is digital, right? And the reason why it's in that order, equity, access, digital, is that if digital isn't helping you with the first two, why are you using it? Right? And I speak as the founder of a digital company. Why are you using it? What's the point of it? Okay? So three challenges. Please feel free to challenge me. You know, I've had a professor challenge. They say, what about quality? And I say, well, within the first two, if quality isn't... What's the point in having equity access by definition, right? Duh. So those three, those are the key challenges facing healthcare systems across the world. But in relation to healthy ageing, it's exactly it's the same. It's a question of equity and access at local level, systems and places. And I'll just tell you, whenever I talk to or think about and talk to system leaders in places around the world, around the country, I always ask them three things as a test for me as to whether I think whatever they're doing is going to work, right? I ask them three questions. The first is, show me the evidence that you use, show me evidence that you understand population health in your area. It doesn't matter whether it's a population of 1.5 million, half a million, or 2 million, right? Show me what is the tool that you've used to understand the population. And if they send me a slide pack done by McKinsey, KPMG, whatever, PwC, no matter how slick it is, I don't believe them, right? If they show me a map, however crudely drawn, which tells me that they've understood visually where the hotspots are, they've got keys, they've got a sense of it visually, I'm more likely to believe them, right? I'm more likely to believe them. That's the first question now. The second question is, show me evidence that this is the map, right? So no matter how many people own the means of production in a particular place, do they all sign up to this is the map? This is the current state, right? Do we all agree that we're here in this place? This is the place. And I want evidence, signatures, in blood preferably, but just show me, right? That's the second question. If the answer to that is, well, you know, we're all working on it and da-da-da, I'm like, okay. Okay. The third question I ask them is, show me the means by which you measure progress. Right? So how do you know you're moving the needle in any of these areas that you consider a priority in terms of public health in this area on this map? And if the answer is, we're working on it, okay, keep working on it, but I'm less likely to believe, you know. Three questions, right? Three things. And it seems to me that that is the fundamental requirement for healthy anything, including ageing, right? My mum lives in Wakefield. Some of you may wonder what she looks like. Well, she looks a bit like me, only older. Right, she's better looking actually, but there you go. And there's a community in Wakefield. There's a Eastern European community. Increasingly, I was the only black person in Wakefield when I was born, but there you go. There's a black community in Wakefield, right? The question, do they have the same needs as the white community? Is there such a thing as the black community? How do you disaggregate that community? What are the needs when disaggregated? Can you meet them in your service design commissioning? What do you understand of that community? Are they involved? Are they engaged? Right? Simple question, straightforward answers. The fact that my mum's 80-odd, hang on, 2 minutes, is vitally important to the answer to the question. If you don't know, how can you plan services? You might as well burn the money. Right? You might as well burn the money. The second issue comes to me is this question of risk when making change, entrepreneurial or otherwise, in healthcare. Often, when people talk about risk, it's not the risk to the patient citizen of not doing the right thing, it's the risk to the organisation of even we never talk about the counterfactual. Honestly, there's so much innovation in health and care that doesn't get beyond that place or that place. Just seen an example of it. That wonderful Active Families operates in the northeast. I bet it operates in one place in the northeast, probably operates in a few, but is it all over the northeast? No. But if you went into it and you talked to some of the organisations involved, they'd talk about risk. But they wouldn't talk about risk from the point of view of the patient citizen. They talk about risk from the point of view of the organisation. Wrong, wrong, wrong. They're not the people taking the risk. The people taking the risk are the people out there. So we need to think about risk in the right way. So, and my final comment is resistance to change. So there's nothing, I think, if you spent a day and a half in this room, you could come up with the means by which you could create healthy living pretty much for everyone in the country. Right? If you get over the risk issue, you've then got the question of change. And I'll just give you a very quick, I haven't got a graph, I can't show you this, but there is a change formula. You'll know this because you're much cleverer than me, you'll know this as well. And it's Bob Beckhart, the Beckhart change formula, and I love it. And it simply states this: change, for the mathematicians amongst you, I can't draw it out, change equals discomfort times vision times a credible first step, all have to be larger than resistance. I'll stop there.
Fantastic. Thank you so much, Victor. Fantastic insights there, and I think really resonate, I'm sure, with some of you who have been trying to get your innovations further spread into health and care. And I hope that you'll put some questions and comments into the Slido so that when we have a few minutes at the end of this, I'll be able to put some of those to Victor. But before we get into the panel discussion, I'd like to invite, hopefully, Rosemary, who's joining us remotely. Hello, Rosemary. To speak to us really from a local authority perspective. So Rosie Sexton is a councillor in Solihull. She is also Deputy Chair of the LGA's Community Wellbeing Board, and by profession, and I think you can see she's probably at work, is an osteopath. So really understands both the worlds of health practice and that of local government, and is going to talk to us on this theme of collaboration. So you have, again, I think about 7 minutes. I'll probably interject if the time runs over, but Rosemary, over to you. You're very welcome.
Hello there, and thank you to Anne for that introduction, and to Victor. I'm sorry I couldn't be there in the room with you today. It looks like you've had a really exciting and energising time, and I'm going to try and make local government interesting for you, but I've had some hard acts to follow. So, as mentioned, I'm representing the Local Government Association, and we're the national voice for local councils in England. It's our role to support, improve and promote councils. So in the few minutes that I have, I'm going to tell you about a few of the things that local councils already do to support healthy ageing. Councils play a key role in ensuring that our communities are stronger, healthier and thriving places to live and grow old in. They're leaders in public health, social care and housing, and are the key commissioners of local voluntary and community services. Councillors are also representatives of the local place with a deep understanding of the needs of local neighbourhoods and communities. We're responsible for a range of vital services for people and businesses in those areas, and among them are the well-known functions such as social care, schools, housing, planning, waste collection, but also ones that get less attention, such as licensing, business support, registrar services and pest control. And as well as delivering local services, councils are at the moment addressing a major reform agenda that has real implications for people in later life. And policy areas that are currently challenging national and local government include how we reform and integrate the NHS with social care and public health in the context of an ageing population, and how to reform the mental health system to improve equity. and then how to increase housing supply, delivery, and building more resilient and healthy neighbourhoods. Now, the pandemic highlighted some of the ways that, some of what can be achieved when government empowers councils and works with them as equal partners to innovate and create services locally. Now, overnight, almost, councils across the country set up completely new services to support the most vulnerable while they were shielding. And drawing on local expertise, councils led partnerships across the public, private and voluntary sector, handling requests for food parcels, financial support and wellbeing issues. Public health is a council function. It aims to improve the health of our population to enable more years to be spent in good health. To achieve this, we need to help reduce health inequalities, like Victor spoke about, across different age and social groups, and invest more carefully to ensure that we have appropriate wellness services. Growing numbers of older people are living with debilitating conditions, and the consequent use of local services can result in negative perceptions of older people as a drain on the system. And this is an unfair perception as well as being unhelpful, because we know that most of our older people live independent, productive lives and are critical to the success of our society. We've got clear examples of the large numbers of older people who are volunteers or unpaid carers, and not to mention the ways in which they can enrich the lives of their family members and the younger generation. However, there are major challenges, particularly around healthy life expectancy. The number of years that people are living with illness and disability is increasing, so that as time goes on, we are living a greater proportion of our lives with disability. The poorest in our society not only live significantly shorter lives than those in wealthier areas, but they also live twice as many years with disability and illness. We see inequalities by level of wealth and between ethnic groups and several other measures of health. The longer a person spends in poor health, the more health and care they need. So tackling this is an absolute priority. But how can we encourage healthy ageing, and how can we shift negative perceptions of older people as a drain on the system? It requires partnership working between councils, the NHS, the voluntary sector, and communities they serve. So these are obvious areas to focus on. As we get older, physical activity levels often decline, and this can lead to becoming more frail, putting us at greater risk of falls and accidents. Social isolation and loneliness is a big factor too, and research has found that it can have serious health effects. But it's never too late to change. Studies show that even a little activity in our 80s and 90s can improve balance, strength, muscle power and blood pressure. If we tackle these challenges in an innovative way, we can help ensure that not only do we add extra years to life, but extra life to those years. There are many innovative council-led examples of how we can promote healthy ageing. For example, Ealing Council, in partnership with the voluntary sector and the NHS, has set up a series of schemes to tackle loneliness and isolation. They include a befriending scheme, which is helping 400 people, and a series of integrated hubs that provide support to another 3,000. Kent County Council have a service called Touch a New World, a free service available to Kent Library customers who are not able to get to their local library. They loan an iPad for up to 8 weeks and offer one-to-one training in the person's own home from a volunteer so they can learn how to use the technology. And many local authorities, including my own, support and promote a range of groups and activities aimed at helping people to maintain or increase their physical activity levels in a way that's enjoyable and meaningful for them. Local government has an opportunity to tackle long-term conditions, turn the health, well-being and independence for us all. However, timing is critical. Across the life course, there may be times when people are more amenable to change, such as after retirement, when children leave home, or when starting to care for older relatives or grandchildren. There are times when people may consider adopting new healthy behaviours, or may be at risk of adopting unhealthy ones. It's also important to note that the burden of risk factors and their consequences are not equally spread across society. Factors such as smoking or lack of exercise are much more common in those with lower incomes and fewer educational qualifications compared to more advantaged groups. For both public health and housing, we need to find more innovative and effective solutions and work with local communities to identify what works in different circumstances. The willingness and drivers Apologies.
I think we can still hear
The
you.
willingness and drive.
Yeah.
Sorry, have I lost you?
No, I think we can still hear you, but are you able just to wrap up? Yeah, I think we had a...
Sorry,
a bit of a blip.
So I just wanted to say that the final thing is that integration is an opportunity for councils and health partners to scale up and focus on inequalities and addressing local needs in a new way. But councils are stretched financially and under the pressure of demand like never before. So finding time and resources to innovate is challenging, but we must do so if we are to achieve long-term change and support resilience and independence as we age.
Fantastic. Thank you very much, Rosie. So I think the Wi-Fi connection just held up there, and we were able to hear you, Rosie. So thank you very much for that contribution. So we've heard from both our speakers a lot about the need to understand properly the needs of the population, to really focus and understand and address inequalities. But we've also heard some of the barriers and challenges and resistance to change, and some of the challenging context, perhaps, that both health and social care find themselves in at the moment, you know, whether that is the lack of workforce, the lack of funding, and so on. So I just wanted to pick up a theme from some of the questions about, particularly given the challenging context in which health and care are currently being delivered, how can we overcome, I suppose, some of that resistance to change, that resistance to adopt innovations, perhaps, that are going on elsewhere? So I'll come to you, Victor, really. What suggestions do you have for how we might overcome that resistance, particularly recognising the challenging context?
I did the Gleicher-Beckhardt formula, didn't I?
Yeah, you did. Yeah.
Well, that's one way.
Yeah.
Recognise it, because dealing with resistance is an OD challenge, a leadership challenge. You know, and in a lot of places it's not recognised as a challenge. So people go ahead with something assuming that everybody's going to, because it's a good idea, and you actually have to manage it. And you know it's a curve, isn't it? You've got some people at the front who are always eager to change, lovely people and all that. The bulk of the people in the middle do just come to work, do the job and go home, right? And then you've got a load of people who hate change, are very resistant to it, and quite passive-aggressive when it comes to, or just aggressive, when it comes to change. And actually you have to deal with all three as though they're humans if you want to move the needle. The other thing I'd say is that orientation is quite important. There's a lovely little graph, actually, Drexler Sibbett, on team building. Some of you may have seen it, but if people aren't orientated, that's why I talk about the map. So if people aren't orientated to where they are, why they are, and who they are with, they will look after themselves. That's what they'll do. So the first thing you've got to do is orientate people to where they are, because that builds trust. And if you build trust, then you can set objectives. And if you set objectives, you'll allocate resources. I've seen billions wasted. And I'm sure, I'll say this and I'll shut up, I'm sure each of you can think of a situation where you've been in a room where an important person walks in, tells you what the objectives are going to be, and you're all sitting there thinking, how do I get out of this room without being embarrassed or shouted at? The person's talking rubbish, but I need to keep my job. So you write down the objectives and you go away and you do them in the way that you think fit, and everybody else does the same thing. And when you come together again, the person shouts at you because you haven't hit the objective. That's because you're not orientated and you don't trust them or each other, and you don't agree this is where you are. So that's how you overcome resistance.
So I thought it was really great, your example of sort of the questions you were posing, and obviously you were thinking about that, I think, in terms of, you know, particularly NHS organisations, but it felt true for me in terms of, you know, where is your evidence of need? Do you have a shared understanding? And I think that's probably as true of innovators, working with older people, working with statutory partners. You know, this is all about, the whole challenge is about collaboration across sectors. And I think really important to ensure that we do have that shared understanding when we embark on change together. Rosie, you may want to sort of pick up that theme of resistance, but there's another question here which I think is sort of building on it, which is, you know, it's very hard in particular for some local authority programmes to be spread to other regions. So we saw this great example, and Victor mentioned it, of Active Families, you know, doing that sort of physical activity work, which you yourself alluded to is so important for healthy ageing. But, you know, with funding and supporting innovations in particular parts of the country, how do we sort of overcome resistance to spread?
Excellent, really good questions. And I think, I mean, the pace of change, it seems to me, has been faster than at any time in the past. We saw this over the course of the pandemic, where we had to innovate and had to change things up rapidly. And we're seeing that at the moment because the pressures on the health system and on social care are like never before. So a lot of innovation is happening through necessity. And I think it's really important that we make sure that when we're doing that, the changes that we're focusing on, we're not throwing the baby out with the bathwater. You know, we're keeping the things that are important to people. For example, when we're talking about bringing digital solutions in, I'm always very keen to make sure that we're not losing those human and interpersonal connections that are so important. When we're talking about spreading things from one area to another, I think that's a really good example because on the one hand, it's important that the solutions we come up with and the particular groups and innovations in any one area are those that that make sense to that particular population or that particular area. And that might not be the same from one place to another, but nonetheless, there will be common principles. So how those are rolled out may vary. We might not see exactly the same interventions, but they will follow a common set of principles. So it's looking at how we can take the essence of a programme and make that appropriate and meaningful to the community we're engaging with.
So, Victor, you stressed this issue about inequalities, and the whole challenge here is about reducing those inequalities in healthy ageing, both not just how long we live, but how long people live in good health. How can we ensure that these great ideas, the innovations that the Challenge has been supporting, actually address those inequalities?
Well, I always make the distinction between inequity and inequality. Because you know the difference, don't you, right? So, and you have to deal with both. You can't just do equality. That's not going to work. You have to have you have to deal with inequity. So, if you want to, the question about spread is a really difficult one because the public sector is really, there's no market. It's not like, you know, all phones now look like iPhones. Why? Because iPhone got massive amount of the market, and all the competitors realised if they wanted to get that, wanted to get some of that market, their phones had to look like iPhones, right? And they had to have this similar technology. In the public sector, they don't have that kind of incentivization. It's not in the same way. We haven't created it. Actually, we could create it if we listened to what I call the patient citizens more, because that's one of the reasons why we got the NHS. It wasn't just, you know, it started in Tredegar, that's the apocryphal story. But the reason why it worked everywhere, pretty much, is because everybody, and this was before Twitter, is because it was an idea that everybody wanted. So everybody said, I want this. Why have I got what they haven't got next door? And people weren't quiet about it. So the difference between then and now, I think, is that we don't involve the patient citizen in the spread, and we don't give them the authority and the power to advocate for what's good. And if they don't advocate it, it's usually an indicator. It's not necessarily the total indicator, but it isn't as good as the people who designed the service think. Do you see what I mean? If it's good, the customers will say, I want this, right? And they'll keep saying it till they get it. If it's not so good, perhaps they won't, right? So I think there's something about how we engage communities in the design and delivery of services. If you do that, they want more of it.
I think that's a great note, I'm afraid, I think, to end. I've already been timed out. So obviously that is very much the spirit of the work here, that is very much user designed, co-designed. So hopefully that means that there will be demand for the products and services that are being created through the challenge, because they are things that we have ourselves designed. But thank you both to Victor and Rosie for joining us this afternoon. If you'll just join me in thanking them both for this session.